Good evening, everyone. So it is my pleasure to invite my esteemed colleague, Dr. Anupama Roy Chowdhury, to present the next lecture. It's a special lecture on holistic strategies in prevention of dementia. So I would like to invite Dr. Anupama on soon. Let me present you a little bit about Dr. Anupama. Dr. Anupama Roy Chowdhury is a senior consultant geriatrician currently working in Sengkang General Hospital, Singapore. She graduated with an MBBS from the National University of Singapore, and she went on to complete her MRCP and specialist training in geriatric medicine in Singapore. Subsequently, she did a 6-month fellowship in Alzheimer's and neurocognitive disorders in the University of British Columbia. She's actively involved in medical education for the undergraduates and postgraduates. Her interests include cognitive disorders, medical education, and geriatric oncology. So I invite Anupama now to take the stage with holistic strategies in the prevention of dementia. Thank you.
We can do to try to reduce our risk and thereby prevent dementia to the best of our abilities. So what is dementia? Dementia is an illness which affects the brain, causing the brain cells to die at a faster rate than normal. It is not considered normal aging. On the left, you see a healthy brain. On the right, you see a shrunken brain, often seen in someone with advanced dementia. Dementia causes a decline in our cognitive function, causing problems with memory, language, attention, visuospatial function, and our ability to plan and make appropriate judgments. This leads to a decline in our ability to perform our activities of daily living, initially with instrumental activities of daily living, such as managing our finances and getting around in the community, and eventually even with our basic activities of daily living, such as showering, dressing, and going to the toilet. In the moderate stages, many people with dementia may exhibit behavioral and psychotic disturbances, such as aggression, agitation, and hallucinations. So why is dementia so concerning? As you can see in this slide, the number of people living with dementia in the world is rising exponentially. According to this World Alzheimer's Report in 2015, the number of people living with dementia is set to rise from 46.8 million in 2015 to 74.7 million in 2030, and then 131.5 million in 2050. Dementia has no cure currently. The current medications available have modest benefits in trying to slow the decline and maintain function. Hence, every attempt to reduce the risk of developing the disease or delaying its onset can make a significant difference at the individual as well as the population level. There are many different types of dementia. These include Alzheimer's, vascular, mixed Alzheimer's and vascular, Lewy body, and frontotemporal dementia, to name a few. This slide illustrates the various types of dementia again and causes of dementia, with Alzheimer's dementia being the most common cause. The pathology in Alzheimer's disease or dementia is due to a buildup of abnormal proteins called amyloid plaques and neurofibrillary tangles, which are toxic to the brain cells, leading to their death. This slide illustrates how abnormal protein buildup can occur for years prior to the person showing symptoms and signs of Alzheimer's dementia. They can be asymptomatic, as in without symptoms, for many years and lead normal lives. With time, a proportion of these people will start experiencing symptoms of memory loss and may enter the stage of mild cognitive impairment, or MCI. In MCI, there is evidence of cognitive decline. There may be problems with memory, planning, etc. However, overall functioning remains intact, with little, if any, interference in daily life. A certain proportion of MCI patients do continue to decline to the dementia stage, where there is significant interference in daily life due to the cognitive issues. This slide again shows how initially there is a buildup of abnormal beta amyloid and tau proteins in the brain, which subsequently leads on to synaptic dysfunction and injury to the brain cells. Brain cell death then leads to neurodegeneration, which can be appreciated in the later stages as shrinkage or atrophy on brain scans. Cognition starts to decline, with individuals initially being categorized as MCI or mild cognitive impairment. Progressive decline affects function, leading to dementia. Hence, there are many years that people spend in the asymptomatic stages when we can try to put in place interventions to reduce the risk of ending up in the dementia stage. The Lancet Commission on Dementia Prevention, Intervention and Care 2020 came up with this life course model showing that 12 potentially modifiable risk factors account for around 40% of worldwide dementias, which consequently could theoretically be prevented or delayed. They divided these risk factors into those that were present in early life, which was defined as less than 45 years of age, midlife, which was 45 to 65 years of age, and later life, which was above the age of 65 years. Less education was identified as an early life risk factor. For midlife, they identified hearing loss, traumatic brain injury, hypertension, alcohol intake of more than 21 units per week, and obesity as risk factors. In later life, they identified smoking, depression, social isolation, physical inactivity, air pollution, and diabetes as potentially modifiable risk factors. Reducing risk factors shown in the top left-hand box that you can see on the slide, such as hypertension, diabetes, head injury, smoking, air pollution, and obesity, helps to reduce neuropathological damage in the brain. Addressing other identified risk factors seen in the bottom left-hand box, such as treating hearing impairment, maintaining frequent social contact, and attaining a high level of education help to maintain and increase cognitive reserve. Some risk factors, such as those seen in the middle box on the left-hand side, including exercise, reducing occurrence of depression, and avoiding excessive alcohol, help reduce neuropathology as well as help with maintaining cognitive reserve. Over the next few slides, I will go through each risk factor one by one. I will be presenting mainly from the 2020 report of the Lancet Commission. We will start off with early life, which is defined as less than 45 years. Higher childhood educational levels and lifelong higher educational attainment reduce dementia risk. Overall cognitive ability increases with education and plateaus in late adolescence. Hence, cognitive stimulation is important in early life in helping to build cognitive reserve. We will now move on to the midlife risk factors, and I will go through them one by one. Hearing impairment. The 2017 Lancet Commission found a relative risk of 1.9 for dementia in populations followed up over 9 to 17 years for those with hearing impairment. A subsequent meta-analysis found an increased risk of dementia per 10 decibels of worsening of hearing loss. In a large 25-year prospective study of almost 4,000 people aged above 65, there was an increased dementia incidence in those with self-reported hearing problems, except those using hearing aids. and hearing aid use was the largest factor protecting from decline. Okay, we now move on to traumatic brain injury. For traumatic brain injury or TBI, mild TBI was defined as a concussion. Severe traumatic brain injury or severe TBI was defined as skull fracture, edema or swelling, brain injury or bleed. In a Danish cohort study of 3 million people aged over 50, followed for a mean of 10 years, found that TBI increased dementia and Alzheimer's disease risk. The risk was highest in the first 6 months after TBI and increased with number of injuries. Another Swedish cohort study, also very large, of 3 million people aged over 50, found an elevated dementia risk with TBI. A single mild TBI increased the risk of dementia less than severe TBI, and multiple TBIs increased the risk further. So in general, the more bad head injuries you have, the higher the risk of developing dementia. Hypertension. Persistent midlife hypertension is associated with an increased risk of dementia in later life. The Framingham Offspring cohort of 1,440 people with 18-year follow-up found that elevated systolic BP of more than 140 millimeters mercury was associated with an increased risk of developing dementia. 4 meta-analyses of blood pressure medications to lower high BP all suggest reduced dementia in the intervention arms. The US and Puerto Rico Systolic Blood Pressure Intervention Trial or SPRINT trial in 9,361 hypertensive adults aged over 50 was actually stopped early because of significantly fewer cardiovascular events and deaths occurring in the intensive treatment arm, which aimed for systolic blood pressure of less than 120 millimeters mercury in comparison with standard treatment of systolic blood pressure less than 140 millimeters mercury. In the SPRINT MIND trial, cognitive assessment was continued after stopping the intervention. They found 7.2 dementia cases per 1,000 person years in the intensive treatment arm versus 8.6 cases per 1,000 person years in the standard treatment arm. So there were less dementia cases in the treatment arm that tried to achieve BP of less than 120. This was the first trial to suggest a reduction of risk for mild cognitive impairment. Drinking less than 21 units of alcohol per week might be associated with a lower risk of dementia. A French 5-year longitudinal study of 31 million people, and this is a large number, admitted to hospital, found that alcohol use disorders was associated with an increased dementia risk. And the association was clearer in earlier onset dementias, or those dementias that develop below the age of 65. Moving on to obesity. Obesity, defined as a BMI of more than or equal to 30, is associated with late life dementia. A meta-analysis of 7 RCTs and 13 longitudinal studies of overweight and obese individuals found that a weight loss of 2 kilos or more was associated with a significant improvement in memory and attention over 8 to 48 weeks. However, data about long-term effects of weight loss in preventing dementia are absent. Finally, we now come to the risk factors in later life, above the age of 65. Smoking. Smokers are at a higher risk of dementia than non-smokers. Stopping smoking reduces this risk. 50,000 men above the age of 60 in a study were found that when they stopped smoking for more than 4 years subsequently, over 8 years they were analyzed, and it was found that stopping smoking for more than 4 years substantially reduced their dementia risk over the subsequent 8 years. Secondhand smoke exposure is not benign, and it may also be significant in worsening cognition, especially in those secondhand smokers who are constantly exposed to smoke. Okay, depression. Symptoms of depression may result from pathological changes in the brain years before onset of a clinical dementia. A meta-analysis of 32 studies with a large number of people followed up from 2 to 17 years found that a depressive episode was a risk factor for dementia. One study looked at treatment of depression with the SSRI class of antidepressants in people with MCI and a history of depression. The Australian Longitudinal Alzheimer's Disease Neuroimaging Initiative found that treatment in this group of people for more than 4 years was associated with a delayed progression to clinical Alzheimer's dementia. COVID has brought about enforced social isolation in an attempt to reduce numbers infected and transmission of the virus. No country has been spared worldwide. Social contact actually enhances cognitive reserve, and studies suggest that less social contact increases the risk of dementia. A systematic review and meta-analysis including 812,047 people worldwide, found dementia risk to be elevated in lifelong single and widowed people when compared to married people. This association was found to be consistent across different socio-cultural settings. A Japanese longitudinal cohort study of people aged over 65 calculated a 5-point social contact scale based on marital status, exchanging support with family members, having contact with friends, participating in community groups, and engaging in paid work. They found that those with the highest score were 46% less likely to develop dementia compared to those in the lowest category. Okay, physical activity or exercise. Moving on to exercise and physical inactivity, meta-analyses of longitudinal observational studies did show that exercise was associated with a reduced risk of dementia. Physical inactivity was more of a risk in those with cardiovascular comorbidities, such as diabetes, hypertension, high cholesterol. Exercise might also be required to be sustained and continued nearer the time of risk. There have been a few meta-analyses on trials of exercise and effects on cognition. In the first meta-analysis here of 39 RCTs examining moderate or vigorous exercise of any frequency lasting 45 to 60 minutes per session in cognitively normal people aged over the age of 50, found that global cognitive improvements were present for moderate or vigorous exercise. In the second RCT, in people with MCI, global cognition improved in the intervention group with aerobic exercise having a higher effect. And in the last one, RCTs of longer-term exercise in people with normal baseline cognition showed an incidence of dementia of 3.7% in those who exercised versus 6.1% in those who didn't exercise. So overall, exercise is beneficial for your heart as well as your brain and general health. Air pollution. Several countries around the world have a problem with air pollution. Animal models suggest that airborne particulate pollutants accelerate neurodegenerative processes. A systematic review of 13 longitudinal studies with 1 to 15-year follow-up of air pollutants exposure and dementia concluded that exposure to fine ambient particulate matter, high nitrogen dioxide concentrations, and carbon monoxide were all associated with increased dementia risk. Diabetes. Recently, the country where I come from, Singapore, declared a war on diabetes because it is just getting more and more common, and it causes a lot of health problems. Diabetes is associated with an increased risk of dementia, and this risk increases with duration and severity of diabetes. One meta-analysis of cohort studies reported that cross-sectionally, people taking metformin, a diabetic drug, had lower prevalence of cognitive impairment and longitudinally reduced the risk of dementia incidence compared with those on other medications. However, another analysis did not find a protective effect of metformin on incident dementia. Hence, whether any particular diabetic medication reduces this risk is unclear. A Cochrane review of intensive versus standard control of diabetes showed no impact on cognitive decline or dementia. Diet. We now move on to the role of diet on prevention in dementia. A Mediterranean diet consists of a high intake of vegetables, legumes, fruits, nuts, cereals, and olive oil, as you can see in this picture, and a low intake of saturated fats and red meat. The WHO Guidelines 2019 recommends a Mediterranean diet to reduce the risk of dementia. Getting adequate sleep is a luxury to some, but getting adequate sleep is important as chronic lack of sleep can cause our mental processes to slow down, affecting our daily function and quality of life. It can also cause us to be irritable and moody. Sleep disturbances, including short and long sleep duration, poor sleep quality, circadian rhythm abnormality, insomnia, and OSA, or obstructive sleep apnea, are associated with a higher risk of dementia. In a study of nearly 8,000 British adults published this year, followed up for more than 25 years, the researchers found that sleeping less than 6 hours per night in their 50s and 60s was associated with an increased risk of dementia. Over the course of this talk, we have looked at individual risk factors separately. The Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability, or FINGER study, was one of the first intervention trials in the world to take a multi-domain approach to dementia prevention. It investigated the effects of a 2-year intervention targeting several lifestyle and vascular risk factors simultaneously. The main aim was to prevent cognitive impairment, and secondary aims included decreasing disability, cardiovascular risk factors and related morbidities, depressive symptoms, and to have beneficial effects on the quality of life. It was a 2-year multi-center randomized control trial with 1,260 participants aged 60 to 77 years. Participants were randomized into either the multi-domain intervention group or the control group. The FINGER multi-domain intervention components were dietary guidance, physical activity, cognitive training and social activities, intensive monitoring and management of metabolic and vascular risk factors, as you can see in this diagram. The control group received regular health advice. At the end of the study, they found a significant beneficial intervention effect on overall cognitive performance. The beneficial effect was seen on each cognitive domain: memory, executive function, and psychomotor speed. This was the first large RCT showing that it is possible to prevent cognitive decline using a multi-domain intervention among older at-risk individuals. So in summary, what can we do to help protect our brain? There are lots of things we can do, as you can see from the data that I have presented in the previous slides. Many of them are quite easily achievable. So in summary, at the personal level, we monitor our blood pressure, treat hypertension, use a hearing aid if we have hearing loss to improve our hearing, avoid excessive drinking, prevent head trauma. If we engage in high-risk sports, it's good to wear a helmet, stop smoking, or at least cut down, reduce obesity, and exercise regularly. At the population level, countries should aim to prioritize childhood education, develop policies that encourage social, cognitive, and physical activity, reduce risk of serious brain trauma, especially in high-risk environments such as construction sites, etc., reduce population exposure to air pollution, and reduce population exposure to smoking. Thank you for your attention.
Thank you, Dr. Anupama Chowdhury, for that very succinct, clear lecture on a very vast topic, which is the holistic strategies in prevention of dementia. So I would like to invite questions from the website or the floor to ask Dr. Anupama questions on her lecture. Shall we open up the floor now to questions? Perhaps I could kick off with a question of my own, Dr. Anupama.
Thanks, Dr. Bharati.
Yes. You know, being the chairperson, at least I get an advantage by bringing in the first question. You know, one of the prevention strategies was social contact. So I was wondering whether you could share with us the data about the risk of dementia during COVID, the past 2 to 3 years, the risk of social isolation and the incidence of dementia that have been on the rise in this time?
Yeah, I can't offhand quote any studies, you know, that have. I mean, COVID is relatively new, as in it just happened end of 2019, early 2020, and I don't think we have actually seen the worst of it yet. But I think there was this study that has been done in China, in Wuhan actually, where it originated, where they first found COVID, where they have noticed cognitive decline, significant cognitive decline post-COVID. But I must say I'm aware of this paper, but I have not read the details yet. Yeah, but anecdotally, in my own practice, and I think this is being seen by other geriatricians and psychogeriatricians, neurologists even worldwide, that the social isolation that COVID resulted in an attempt to try to curb the numbers, we did see patients cognitively declining at a pretty alarming rate, at a much faster rate than you know, we had noticed before. People who were compensating by keeping themselves active, by exercising in groups, by meeting friends, going on holidays, doing group activities like mahjong, karaoke. These were strategies, I think, that they were using to keep themselves socially and cognitively active. And when that stopped, we actually saw them declining and many actually progressing, unfortunately, to dementia. Yeah, but like we've got a wave now in Singapore, and we are noticing that post-COVID, you know, even if they don't develop a very bad pneumonia, or you know, it doesn't really affect their chest that badly, we do see them becoming very delirious, prolonged delirium, apathetic, poor feeding. So yeah, we're seeing these problems on the ground.
Thank you, Dr. Anupama, for sharing your clinical experience in this. I agree with you, and I concur that consistently we are seeing that from the clinical practice point of view, and only time will tell the impact of COVID in the decade to come. So moving on, we have a question from the website. Not sure whether it's probably something that you could maybe discuss. Is a question asking if tinnitus can cause dementia.
Yeah, so tinnitus is just a term used for this ringing in the ears, and tinnitus itself does not cause dementia, has not been associated with dementia, but it is loss of hearing, hearing impairment that has been identified as a risk factor. So tinnitus is a symptom of ringing in the ears. It may or may not be accompanied by hearing loss, but by itself, it does not cause dementia, but hearing loss has been associated with dementia. I think because it also kind of socially isolates the person to some degree.
Yeah, that's a very interesting trajectory, because of tinnitus and perhaps social isolation. Yeah. Are there any further questions from the website or any questions from the floor, please? Okay, I think your talk must have been very, very clear, Dr. Anupama. So far there are no questions further. Perhaps we could then close here. And thank you for this time and for you to take this time off of your busy schedule at the hospital. And I understand that things have been so intense over in your wards. Thank you for this time, Dr. Anupama, and thank you everyone for listening in and for attending this talk.
Thanks very much, Dr. Bharti, and thanks once again for all the admin support as well as the organizers for giving me this opportunity to share. Thank you.
Thank you.